So these are some of the questions that I asked you. The ideal age is about 12 to 18 months. And the answer he said is allow the growth of the penis to have sufficient material. And can hypospadias occur in female? Yes, rarely it can occur in female, but not very common. And if it is identified by urine pouring out through the vagina also, while the child tries to pass urine. And what are the complaints which patients have for hypospadia? Visible abnormal opening, urethral opening, the tip of the instead of the tip of the glans penis, deviated stream of urine soiling the clothes, abnormal shape of the penis, and the tip may be bent vertically, ventrally during erection. Surgical procedures are mild hypospadias corrected by single stage procedure. Several severe hypospadias require two-stage procedure using skin of the prepuce to construct the urethra. Sometimes, as he rightly said, buccal mucosa may be used for reconstruction. And the challenges in providing anesthesia are, can you tell me what are the challenges in this hypospadias repair patients? Are you there, Mohit?
Regarding, sir, yes,
the common challenges in providing anesthesia for hypospadias in a child. You can classify them as challenges of pediatric anesthesia, need for adequate post-op pain relief to prevent the child trying to handle. Sometimes, if they don't give adequate pain relief, they pull at the penis and they disrupt the sutures and the repair will be totally gone. And it may be done as a daycare procedure. So you have to face all the problems of daycare anesthesia, like ensuring that they are adequately staffed, meal per oral guidelines have been properly followed, and they have not developed any URI on the day of surgery, because you see them make an assessment in the preoperative day, a couple of days earlier itself. So all those problems are there. And anesthesia can be routine preoperative assessment to assess the growth, development, birth history, recurrent UTI, URI, anemia, renal dysfunction. Associated congenital anomalies, even though they are not very common, you have to look for them. And children, older children who come for repeated procedures, because it may be done in stage procedures, or there may be complications like a fistula after repair or a stenosis. So these children get a little psychologically and emotionally upset because of the repeated visits and then IV line poking and hospital environment. So they get psychologically upset. So that may be a challenging thing that can happen. And NPO guidelines should be insisted. And you can give midazolam orally as a 0.5 milligram per kg 30 minutes prior to surgery for managing the keeping the patient quiet and cooperative. And the choice of anesthesia can be regional, general, or regional combined with GA. And the regional techniques can be penile block for distal hypospadias near the glands, which is a short duration surgery. And you can do it with IV sedation and penile block. And caudal epidural anesthesia using LA drugs with or without additives is another option. So if you are going to do it as a daycare procedure, adding additives will give a prolonged pain relief. So patient will be comfortable even at home also. So the methods of penile block are, this is called the ring block, where you inject the drug in the 12 o'clock, 3 o'clock and 9 o'clock position, subcutaneously infiltrating all around the root of the penis. And that will give a good anesthesia of the entire penile structure. And this is how you do the actual live procedure like this. So this is called landmark-based dorsal nerve of penis block. And you can use an ultrasound to block this nerve also by in plane and out of plane techniques, as Dr. Mohit said. This is US guided penile block. And in the ultrasound, you can see these structures. Can you expand all these acronyms or short forms, Mohit?
Sir, CC is for the corpus cavernosum. And then it's lower is corpus spongiosum. Then there's a deep vein, deep vein,
Dorsal penile artery.
dorsal penile artery, dorsal.
This is
Dorsal.
dorsal penile artery vein.
Deep dorsal vein.
BF. BF is the Buck's fascia. Okay.
And Buck's fascia.
These are all the images that you can see in that. And the caudal is performed in children either by landmark technique using these 3 points: posterior superior leg spine and the sacral hiatus. And this is how the needle, first you strike at an angle of 45 degrees. So you can see this is the angulation that is done. So this is totally 90 degrees. So you insert at an angle of 45 and then gradually bring down the needle and enter this into the caudal space. And this is in this particular technique, is it done by a single person or 2 persons?
Sir, for drug we require the second person, sir.
So this is a 2% technique, isn't it?
Yes, sir.
So this person is identifying the space with a probe of the ultrasound, and he has already inserted the needle. There is an extension tube, and the second person, without the gloved hand, they are injecting the drug. Okay, and the advantage, as I said, is you can see the local anesthetic spread here. You can see the dural sac. Okay, so these are all the advantages. So US guided, it is done by 2 persons. Advantage are need tip is constantly under vision. So the needle will not move. You can see the needle position. Correct placement of LA drug is also seen. What is Scott's calculation of LA drug for caudal block? In which category of patients you should avoid it? Normally for caudal block calculation of local anesthetic, which formula you use?
Armitage formula.
Armitage formula, modified Armitage formula we use. Have you heard of this Scott's calculation?
No, sir.
Calculate the dose based on child's age and or weight table, which is already available. If the child is of average weight for his height and leg, then it is very useful. The figures will be the same. But it should be avoided in obese children who are more overweight, because it is based on weight also. If you give a overdosage. So this is the Scott's calculation table. So if the child, you take into consideration both the age of the child and the weight of the child, and that will be 2 years age and 12.5 weight, which will give you, if you want a block up to T12, you have to give 4 ml. If you want a block up to 7, is 6 ml. Like that, you can go on increasing maximum up to 10 years. This calculation holds good. And at 10 years, you expect the child to be about 30 kg in weight. So the Scott's calculation, unlike your Armitage calculation, where you decide the volume and concentration up to the level of the block that you want, like sacral, lower inguinal, mid-thoracic, higher thoracic, like that. In Armitage, that is the criteria taken for the calculation, whereas in Scott's calculation, both age and weight is calculated. I have just given it in case you answer very well and the examiner asks you this, but this is not practically useful. Armitage is much more easier to remember and calculate, and that is what the examiners also want you to say if they ask you. But if you perform very well, to give you extra marks, sometimes they may ask you about this. So just remember that Scott's calculation is both for age as well as for weight, and the level is only 2 levels are taken into consideration: block up to T12 and the block up to T7. Unlike Armitage, where you do sacral, lower lumbar, then mid-thoracic, high thoracic, like that. Okay. So these are all the things that I just wanted to share with you in this particular thing. Okay. You think, are you both happy?